Module 14, Chapter 17. Now, let's turn our attention to the posterior lobe of your pituitary gland. Now remember, the hormones being released from the posterior lobe are actually made by the hypothalamus. So in the figure above, you can see the hypothalamus and its neurons in blue, and you can see that these hypothalamic neurons extend axons that travel down the posterior portion of the infundibulum and into your posterior lobe. Now, when triggered, your posterior lobe will secrete the hormones as needed. One of the hormones that's going to be stored and released is oxytocin, which is abbreviated OT. Now in females, oxytocin stimulates uterine contractions during labor and delivery, but later, when nursing the infant, the oxytocin promotes milk ejection. Now, these are honestly the two most known functions of oxytocin. However, it's very misleading because people assume that this is a hormone in pregnant women, it's for nursing women. However, it is produced in males, and it is produced in non-pregnant females who aren't nursing. Now, in these particular individuals, oxytocin is believed to promote parental caretaking behaviors. So it's that emotional bonding between you and your children, and it gives you that desire to take care of them. It also plays a role in the creation of sexual pleasure during and after intercourse. It plays a role with orgasm. They believe that it does play a role with sexual affection, helping to bond the male to the female and female to the male. It is believed to play a role in possibly in the ejaculation process. It might contribute to some of the muscular contractions that are involved in the sperm transport portion. It also may play a role in the uterine contractions that also help to move sperm throughout the female reproductive tract after ejaculation. The second hormone released from the posterior lobe, is antidiuretic hormone, or ADH. Now, you learned for the last exam the different triggers that would cause it to be released, such as an increase in the osmotic concentration of your blood, so an increase in your blood electrolyte levels, which shifts the balance between, quote, solids and liquid. Also a decrease in blood volume, which leads to a decrease in blood pressure. ADH is also released in response to angiotensin II. Now, with regards to what ADH will do, the effect that you became familiar with was that it reduces your urine production. Basically, ADH tells the kidney, conserve water. So water is pulled out of your future urine and it's put into your blood. So blood volume increases as a result, but urine volume then decreases. In addition to this, antidiuretic hormone does also reduce water loss in sweat, so it actually inhibits eccrine sweat gland production so that you're not losing water volume across the surface of the skin. It also, at very high levels, can cause vasoconstriction, which would increase resistance and increase blood pressure. Now, what's interesting is alcohol actually inhibits the release of antidiuretic hormone. So think about it. You're drinking alcohol, and what's one of the things that will normally happen as you drink alcohol? And I'm sure since we're talking about water, you're thinking, yeah, you start to pee more, you start to urinate more frequently. Well, that's because of the loss of ADH. If you stop releasing ADH, you lose all of these effects, meaning you now are no longer conserving water at the kidney, you're promoting water loss at the kidney. So your urine volume is actually going to go up as you are drinking the alcohol. Now, this will lead to dehydration quite easily because you're losing extra water, blood volume's going down. This is going to start pulling water out of your tissues, and your tissues are going to get dehydrated. And did you ever hear that after having some alcohol the night before, you can wake up very thirsty with a pretty severe headache the next day? Well, that thirst and headache is actually caused by the dehydration. So it's recommended that if you are going to have alcohol, that for every one alcoholic beverage, you drink at least an equal volume of water to try to offset the water loss. And it's the one thing that people won't do, especially if there is bathroom accessibility issues, because waiting in line for a long period of time could lead to issues. If there aren't bathroom facilities where you are, so people will not drink the water because they don't want to encourage more urination than they're already experiencing. However, if you do want to avoid the thirst and headache, it is what you need to do. At least if you do wake up with the headache, increasing your water intake that morning will help resolve the headache, but do not drink caffeine. The caffeine is going to increase your urine production, and it's just going to make the dehydration worse. Now, I also wanted to take a moment to mention a disorder related to antidiuretic hormone called diabetes insipidus. Now, diabetes means overflow. The insipidus means it's tasteless. So, in diabetes insipidus, you would have the large volume of urine production, except there's no glucose in it. It's very watery urine, so it doesn't have that sweet taste like you have with diabetes mellitus. Now, diabetes insipidus has two potential causes. One is hyposecretion of ADH. So that means your hypothalamus is not capable of making the ADH, so there's no ADH to be released from the posterior lobe. One cause. Another possible cause is that you can produce the ADH, but the receptors for ADH in the body are non-functional. So even though you have the hormone, your cells can't bind it and have an effect. Now, both of these are going to basically create the same effect as alcohol. You're going to start to excrete very large volumes of urine. We are talking up to about 10 liters of water per day. Okay, 10 liters of urine volume, and it's almost pure water. Now, I don't know about you, but I can't drink 10 liters of water per day. And that's basically what you would have to do. For all the water that you are losing in your urine, you would have to replace that at a steady rate throughout the entire day. Not to mention, what do you do in the evening when you're sleeping? Now, you can lose so much water that you could actually die of this within 1 to 2 days of dehydration. So this is not something inconsequential. This is a really serious disorder, very life-threatening. Now, there is a treatment for it. There is a drug that you get. It's called desmopressin. It's a nasal spray. So the desmopressin can be absorbed across the nasal mucosa directly into the blood. And desmopressin is antidiuretic hormone. It's just the pharmaceutical industry has to call it something else because they made it. It's not a hormone being made by your body. Now, desmopressin is only effective if your cause is hyposecretion of ADH. It will supplement in the ADH that you can't make. However, you could put as much nasal spray up your nose as possible. If your receptors don't work, the therapy won't work because it won't be able to bind the chemical. So if you had to get diabetes insipidus and you had to pick which kind you wanted to have, you pick the hyposecretion. The desmopressin has been proven for decades to be very effective at treating that particular type of diabetes insipidus. All right, so now let's move out of your skull, completely leave your hypothalamus, leave your pituitary behind. We're going to go down into the anterior region of your neck, just inferior to your larynx, which is your voice box, and we're going to talk about your thyroid gland. Now, the thyroid gland is the largest endocrine gland. Structurally, as you can see here in the left-hand image, you have two lobes, one on the right and one on the left, and they're connected across the anterior midline by a little bridge of tissue called the isthmus. Now, your thyroid gland has one of the highest perfusion rates in the body. That means it has one of the highest rates of blood flow per gram of tissue. Now, if you look inside the thyroid, which is the image over on the right-hand side, you can see that the inside of the thyroid is divided into these weird circular-looking structures. These circular-looking structures are called thyroid follicles, and they consist of a layer of follicular cells along the outer edge surrounding a follicle cavity. Now, these thyroid follicles are responsible for producing two hormones. One is called thyroxine, or T4. Now, the 4 means that the hormone requires 4 iodide ions in order to be functional. The other hormone is triiodothyronine, or T3. The 3 means that you need 3 iodide ions for the hormone to be functional. Now, the thyroid gland is kind of unique in terms of how it forms and stores this hormone. It is the only gland in the human body that can actually store its products in large quantities. It is estimated that your thyroid gland actually stores a 100-day supply of thyroid hormone. That is how important that hormone is to maintaining your homeostasis, that you would store that much. Now, to actually make the hormone, the follicular cells are going to take the amino acid tyrosine. They're going to modify it, convert it, add things to it, and form a chemical called thyroglobulin. Thyroglobulin is put into the follicle cavity, and in that cavity, it's going to combine with the iodide ions to form the final T4 and T3 hormones. Now, T4 and T3 do have some of their own unique functions, but for our level of A&P, to meet our learning outcomes, we can talk about these hormones more collectively. So we're going to talk about the effects of both of these hormones together as a unit. And the first action is they're going to increase something called your basal metabolic rate, or BMR. Now, your BMR is the rate of oxygen consumption in the body under basal conditions. Basal conditions are when you are awake, you are resting, and you are fasting. Now, think about what you use oxygen for. You use oxygen for ATP production. So your BMR basically is the rate of ATP production under basal conditions, except how you measure BMR is by looking at oxygen consumption, because that's measurable. Now, what T3 and T4 will do is they will increase this rate. So we're going to increase our oxygen use, meaning we are increasing our ATP production. Now, this increase in BMR is going to help stimulate many different types of metabolic processes. For example, it helps you with accelerating the breakdown of carbs and proteins and lipids. It helps you increase cholesterol excretion. So these hormones actually can stimulate your metabolism to the point where they can lower blood cholesterol levels. So this is your natural lipitor, basically. Now, this is actually how, this one function is how they actually diagnosed my husband with being hypothyroid, not enough thyroid hormone. I made him go for his annual physical 13 years ago when we moved here, and that was a feat unto itself. But when his blood work came back, he came back with really high cholesterol. And luckily, he had a physician um, who considered his age because he was still early 30s, and the how high that cholesterol was didn't quite match with the age that he was or his activity level. So he knew enough, okay, the physician knew enough to do a thyroid panel and actually found that he was hypothyroid. Um, they sent him to an endocrinologist. They put him on the synthroid replacement, the artificial thyroid hormone replacement. And over the next few months of being on that thyroid supplement, his cholesterol levels dropped back down to homeostasis. And they've stayed there since for 13 years now. So this is a pretty significant effect of this hormone, that it can help you to excrete cholesterol from the body. So if you are ever told you have high cholesterol, ask them to check your thyroid. It's not something that a lot of physicians will jump to, but if it is a thyroid issue, it's a great way to head it off at the pass before you go on to drugs like Lipitor that can lead to long-term liver damage with long-term use. In addition to stimulating metabolism, thyroid hormone, kind of under this increase in BMR, causes a calorogenic effect that actually raises body temperature. T3 and T4 have the ability to increase the number of sodium-potassium pumps in the body. Now, these little sodium-potassium pumps have cropped up with all of your muscle and nervous physiology. And what you've heard about them is that they are active transport pumps, meaning they use ATP to move the sodium and the potassium. Now, ATP use releases heat. So now follow the train of thought. If you increase the number of sodium and potassium pumps, wouldn't you increase the amount of ATP they're using? And if they're using more ATP, wouldn't they be releasing more heat inside the body? And that is where you get the ability to raise body temperature. You heard for lecture exam number 1 that these hormones have the ability to increase heart rate and increase contractility. Now, the increase in contractility leads to an increase in stroke volume. So the increase in heart rate with the increase in stroke volume leads to an increase in cardiac output, which very nicely increases your blood pressure. These hormones enhance your sensitivity to sympathetic stimulation, and they do this by upregulating epinephrine and norepinephrine receptors. So it's going to put more of those receptors in the plasma membrane, so that when you do have these hormones in the blood, your cells are going to respond more greatly than they would normally. And remember, these hormones are involved in your fight and flight response. Your thyroid hormones also promote alertness and quicker reflexes, which would play in with the sympathetic stimulation as well. They stimulate your appetite. They increase your respiratory rate. Now ask yourself this one. If you increase your respiratory rate, aren't you going to be bringing more oxygen into the lungs? The answer is yes. And the more oxygen that comes into the lungs, the more oxygen that can diffuse into your blood. And isn't the first effect of these hormones to increase your BMR, increase your rate of oxygen consumption? So wouldn't you have to have an increase in oxygen diffusion in the lungs to support that first effect? It's going to stimulate erythropoiesis. So this is going to increase our red blood cell number. Well, If we need more oxygen exchanged at the lungs, we need more red blood cells to pick up that oxygen and transport it. These hormones are going to increase growth hormone secretion, so thyroid hormone in its own way helps to promote body growth. It promotes the growth of bones and skin and hair and nails and teeth. It even helps to promote development of the fetal nervous system, the fetal skeletal system, and the fetal muscular system. Now, when we did our anterior lobe of the pituitary, we talked about how the thyroid is regulated when we discussed thyroid stimulating hormone. But I want to make sure we review that so that you feel more confident with the information. Now, when you start thinking about controlling T3 and T4 production, one of the controls is actually dietary. In order to finish making the hormones, you need to have iodide ions. Now, usually you get about 500 micrograms of iodide in your diet per day, thanks to all of the iodide that's added into things like the salt that you sprinkle onto your food and other preserved foods. And that 500 micrograms per day is 3 times more than what is needed for you to support your daily thyroid hormone production. However, if you're iodide deficient, then you can't produce this hormone. So there is a dietary requirement. You also had the hormonal control that we talked about. So now imagine wee little hypothalamus detects that you have very low circulating, meaning in your blood, levels of thyroid hormone. If your blood levels are low, your hypothalamus increases TRH production. The TRH travels through the anterior lobe and it causes your thyrotropic cells to increase thyroid stimulating hormone production. The TSH travels through your blood, goes to the thyroid gland, and increases thyroid hormone production at your thyroid gland, which will then bring your blood levels back to homeostasis. If your blood levels, though, are high, your hypothalamus will turn off TRH production, which in turn tells the thyrotropic cells of your anterior lobe to turn off thyroid stimulating hormone production. The loss of TSH tells your thyroid stop producing thyroid hormone, which is what you want, because your levels are already high. So when you start thinking about hormones and how they're balanced, you're either going to use hormones to make a problem better, or at least keep it from getting worse. Now, in addition to the dietary control, in addition to the hormonal control, there are some ATP demanding conditions, conditions that your body can be in that require higher levels of ATP production to support. And these conditions could hijack this system, cause you to increase your thyroid hormone production without the hormones at all. So some examples of these conditions could be being in a cold environment, hypoglycemia, living at really high altitudes, and pregnancy. Now, also within your thyroid gland, you have another group of cells. They are called C cells or parafollicular cells. These cells are located in between the thyroid follicles, and they play no role at all in the production of thyroid hormone. Instead, these cells are going to produce a hormone called calcitonin, and they produce calcitonin whenever blood calcium becomes elevated. So these little cells are actually capable, all on their own, of measuring blood calcium. And when blood calcium levels get elevated, the C cells respond by making calcitonin. Now, calcitonin is most important in growing children. It doesn't have as much of an effect in adults. However, It is produced and it does inhibit bone loss in pregnant women and in lactating mothers. So in adults, not so much of a role unless you are in those extreme situations. Now, I know that I covered calcitonin in Chapter 7 of A&P1, but I do want to review it just in case your A&P1 instructor didn't cover them. Now, when calcitonin is produced, one thing it's going to do is inhibit your osteoclasts. Now, osteoclasts, as you recall from A&P1, break down bone matrix. And when they break that matrix down, they release the calcium back into your blood. So osteoclasts raise blood calcium. Well, now think about what started all of this. Blood calcium is abnormally high. So you want to inhibit the osteoclasts because their function would make your problem worse. So we're going to turn them off. We're then going to promote the activity of our osteoblasts. Remember, osteoblasts are your builders. They built bone matrix. So they are going to promote bone deposition, meaning they're going to encourage calcium to be pulled out of your blood into your bones and be used to build matrix. By pulling the calcium out of the blood, you're going to lower blood calciums back to normal. So the overall effect of calcitonin is to actually lower your blood calcium back to homeostasis. All right, so now let's talk a little bit about some disorders of your thyroid gland. All right, we're going to start with hypothyroidism. Now, hypo means too little. So hypothyroidism means you have abnormally low levels of thyroid hormone. The first hypothyroidism I want to mention is not that common in the United States. It's more common in third world countries where you don't have the medical care needed in infancy and childhood. And this disorder is called cretinism, which is the image of the individual on the right-hand side. Now, cretinism, also referred to as congenital hypothyroidism, is a hypothyroidism that exists from the moment you are born. So these infants are born without the ability to produce thyroid hormone. Now, in the United States, they will heel stick an infant and collect a small sample of blood. And what they do look for, one of the things they look for is thyroid hormone to make sure that the infant is producing thyroid hormone on its own. Now, remember, with all of those functions of thyroid hormone, the very last one was promoting the development of the fetal nervous system, skeletal system, and muscular system. Well, the thing is that in cretinism, you don't have the thyroid hormone to promote that development. So the individual ends up with severe mental retardation, stunted bone growth, stunted muscular growth. You can see this individual excessive adipose deposits. That's also due to a sluggish metabolism because they don't have that thyroid hormone to increase their BMR. Now, if the individual is suffering from cretinism, it's been allowed to advance to this particular stage. Supplementing with thyroid hormone at this point would not fix the developmental damage, which is why you need to find out in your infant as soon as possible if there is a thyroid hormone issue. And as long as you supplement them with the thyroid hormone, development can occur normally. Myxedema is also hypothyroidism, but it's hypothyroidism as an adult. So it's not going to affect your developmental processes in any way. Now, myxedema is 5 times more common in females than in males. It has a wide range of symptoms, any combination of which is going to get you to the doctor, and it's going to give off clues to the doctor that they need to do some blood work and check out this gland. For example, they get a lot of facial edema, their heart rate is low, Their overall body temperature is very low. They're going to have an increase in their cold sensitivity, dry hair and skin. They're going to start seeing weight gain because their BMR is dropping, muscular weakness. They're going to have lethargy. They're going to feel tired because they can't produce that ATP. Now, hyperthyroidism is going to be excessively high levels of thyroid hormone, and one cause of hyperthyroidism is Graves' disease. Now, Graves' disease, again, is 7 to 10 times more likely in females than males. And what happens in Graves' disease is that you start to produce antibodies that mimic thyroid stimulating hormone. So the TSH is not coming from the anterior lobe, it's coming from your lymphoid system. And these antibodies go to your thyroid gland and basically provide a permanent on switch where they just turn this gland on and it just runs and runs and runs and runs and runs, producing really high levels of thyroid hormone. Now, there are some interesting symptoms of this, and they're opposite basically of myxedema. The image of Graves' disease here on the screen, you can see one obvious symptom in here. It's called an exophthalmic goiter. And what this is a swelling of the tissues surrounding and behind the eye. And when the tissue swells, it pushes the eyeball further anterior, creating what you might refer to as that bug-eyed appearance. These individuals also have excessive weight loss because their BMR is amped up well beyond where it should be. They're very irritable. They suffer sleeplessness. They're very jittery. They can't settle down because everything is amped up. They're very restless. Where I worked before coming here at St. Vincent's, there was actually a student with this in my comparative anatomy class. And she stopped by my office to talk about it and kind of asked me to clarify a few things for her about the biology behind it. She was given with two options at this time. Now consider this was 13 years ago, more than 13 years ago. Her options were to have radioactive iodine treatments. Now, the radioactive iodine would go to the thyroid gland and intentionally destroy a significant portion of the gland. The thought being that if the gland as a whole is overactive, if you destroy a significant part of it, the portion of the gland that is remaining might produce normal levels of the hormone. The only problem is the radioactive iodine would also penetrate into other body structures, in particular the ovaries, and cause potential mutations in the, quote, eggs stored in the ovaries. Now, the poor girl is 20 years old, no boyfriend, she's not married, and wanted a family one day. So she went with option number 2, which was the actual surgical removal of half of her thyroid gland. When she had it done over the summer, she checked back in with me when school began again in August, and the removal of half the gland dropped her thyroid hormone levels enough that she was within healthy homeostatic range without having to actually supplement with Synthroid. So they removed just the right amount, and she was complete 180 with regards to her mental processing and everything. All right, now let's talk about goiter, which is the little thing in the middle. Goiter is an enlarged thyroid. It's due to an increase in fluid retention within the gland due to chronic stimulation. And believe it or not, you can get goiter with hypo, hyper, or what is called euthyroidism. That's EU thyroidism. Now, euthyroidism is a completely normal, healthy, functioning thyroid. The problem is you have an iodide deficiency, and that's actually what the woman on the screen is suffering from, an iodide deficiency. Without the iodide, you can't make the thyroid hormone, so your blood levels are constantly low. Well, your hypothalamus doesn't know it's a dietary deficiency. All it knows is that your levels of hormone are too low. It turns on the pituitary, and then the pituitary sends out thyroid stimulating hormone. It stimulates the gland, which is contributing to the swelling, but the stimulation is pointless because you still can't make the hormone. And it begins a positive feedback cycle of sorts, where your hypothalamus stays on, your pituitary stays on, you're chronically stimulating your thyroid gland to no avail. You can't make the hormone. Now, it's very easy to treat and rectify. All you have to do is supplement in the iodide. The moment you give the person iodide on a daily basis, the buildup of thyroglobulin in the thyroid gland will eventually subside. You'll build up thyroid hormone in the blood, which is going to allow your hypothalamus to turn off, your pituitary to turn off. Your thyroid won't be chronically stimulated by TSH, and eventually the signs of goiter will be gone. With hypothyroidism, your gland is non-functional. You can't make the hormone. So it would lead to the exact same thing. If you can't make the hormone, your blood levels are extremely low, and it's just going to cause your everything to stay on, that chronic stimulation of TSH on the gland, and it's going to make it swell. With hyperthyroidism, you have antibodies constantly barraging your thyroid gland like TSH would. So your antibodies are going to keep your thyroid gland in a state of stimulation, causing it to overproduce thyroid hormone. And that overstimulation of the gland is not just going to increase hormone production, but it's going to cause fluid accumulation in the gland as well. Now we're going to stay in the neck, except we're going to go to the posterior side of the neck, and we're going to look at the posterior surface of your thyroid gland. On this posterior surface, you have what are called parathyroid glands. You've got two pairs of these little glands tucked away on your posterior surface. Now inside the gland, you're going to have two different types of epithelial cells. You have parathyroid cells and you have oxyphils. The parathyroid cells produce a hormone called parathyroid hormone. Now the oxyphils are living. No one knows what they do though, so their functions are undetermined. So we're going to focus in for this chapter on the parathyroid cells and the parathyroid hormone that they produce. Now, PTH is produced when blood calcium levels get too low. Now, PTH does regulate calcium and phosphate ions, but we're going to focus in on the calcium. Now, when blood calcium is low, your wee little parathyroid glands, who are monitoring blood calcium, they're going to recognize this problem, and they are going to start producing PTH. Now, PTH is basically going to initiate a three-pronged attack to fix your calcium and get it back up to normal levels. The first thing it's going to do is it's going to increase the number and the activity of your osteoclasts. Now, that means we're going to be breaking down your bone matrix at a higher rate, which means we're going to be releasing calcium from your bones into your blood. That's going to help to raise your blood calcium. At the same time, though, we need to inhibit the osteoblasts because those builders are going to help to promote bone deposition, and we don't want that. Bone deposition would pull calcium out of our blood and make our levels lower than they already are. So we want to shut that down. PTH is then also going to talk to the kidney. It's going to tell your kidney to start reabsorbing calcium. Now, reabsorption is conservation. It's telling the kidney grab calcium from your urine and return that calcium to the blood. So we're going to start pulling calcium out of the blood and we're going to return it, or pardon me, out of your urine, and we're going to return it to your blood. At the same time, your kidney is going to increase phosphate excretion. So we're going to pull more phosphate from your blood and into your urine. However, since we are focusing on blood calcium regulation, by reabsorbing the calcium, by returning it to your blood, we're going to help to raise our blood calcium. PTH also then tells the kidney to promote calcitriol formation. Now, calcitriol, as you recall from Chapter 6 in A&P1, is your active form of vitamin D. So, PTH causes your kidney to make more calcitriol. Now, calcitriol is going to go to your intestines, and calcitriol at the intestines is going to increase calcium absorption from your food. So that means you're going to pull more calcium from your food and into your blood, which is also going to help increase your calcium back to homeostasis.